As you hear, the talk today will be about pulmonary hypertension and management in the treatment-naive patient. So I'll start. This is my disclaimer. And to start with, let's really agree about what's pulmonary hypertension. And to a great extent, pulmonary hypertension per se is not a disease. It's just like a hemodynamic state as measured during right heart cath. Whenever we have a pressure or the mean pressure more than 20, then the phenomenon or the hemodynamic state of pulmonary hypertension is diagnosed. And this basically hemodynamic state could be associated with many, many diseases. And whenever you have pulmonary hypertension with any disease, the outcome is usually worse. So let's say if you have a heart failure with or without pulmonary hypertension with the same ejection fraction, those people with pulmonary hypertension will have worse outcome. Very similarly, if you have somebody with a COPD with or without pulmonary hypertension at the same level of lung function, same level of oxygenation, those with pulmonary hypertension will do much worse. How bad is pulmonary hypertension? And indeed, it's one of the worst disease when it comes to the prognosis. And this was the initial work with a really NIH registry looking at all comer with pulmonary hypertension to find out that about 50% of them will die in less than 3 years. So that was the initial alarming basically information. And later on, we recognize that if you look at the outcome of the pulmonary hypertension, at least advanced pulmonary hypertension, that's what we call class 4 function class, those people have very similar mortality to the most aggressive cancer, including lung cancer and pancreatic cancer. So the disease is highly, highly fatal. So this is our own data trying to look at those patients in Saudi Arabia, and we found out that most of those patients who presented to us, they were quite an advanced stage. They were in function class 3 or 4, and it took them up to 27.8 months before the diagnosis is basically established. So this means that those patients, they were actually wandering around from doctor to doctor, complaining of dyspnea, and they were given different diagnoses, including asthma, bronchitis, deconditioning, etc. And it took them about 28 months before the diagnosis gets established. So when we look at that really phenomenon of really mean pulmonary artery pressure more than really 20, now the new world classification, WHO, has classified the disease into 5 groups, group 1, 2, 3, 4, 5. Depends on the pathophysiology, location of the disease, response to therapy, etc. And among those 5 groups that we have, group 1 that we call PAH, pulmonary arterial hypertension. Group 2, 3, 4, and 5 are actually pulmonary hypertension. Group 2 are those who have left heart disease associated pulmonary hypertension. Group 3 are the lung disease and hypoxia associated. Group 4 are the chronic thromboembolic, and group 5 are the multifactorial. And this was a nice work done by Maris Hooper from Germany, where looked at among those 5 groups, and we found out that globally, group 2 and group 3 are the most common one. So those are who have left heart disease induced pulmonary hypertension, and those who have really lung diseases induced pulmonary hypertension were the most common worldwide. So again, this is the same classification, looking for group 1 at the pulmonary arterial hypertension, then group 2, left heart disease induced, and the subclassification of each group. And again, as I said, that the reason these were classified is because of different pathophysiology that we need to understand when we start managing patient who comes for the first time as a treatment naive, because it's very, very important to classify the patient into specific disease or specific group. So we know that, for example, in group 1, those people usually, they have what we call a state of cell proliferation, increased mitotic activity. So basically all cell layers in the intima, media, and adventitia continue to basically proliferate. The old cell do not die, so there is really basically very blunted apoptosis, and that leads eventually to the occlusion of the pulmonary vessel. So basically the lumen will be obliterated with kind of partial recanalization, and we call that process plexiform lesion, which is very typical for a group 1 disease. And this is, if you think about it, increased cell proliferation, decrease basically apoptosis. That's very cancer-like basically mechanism. Now in group 2, the really mechanism is very different. The whole thing's happening is the increased pressure in the left heart. And now the right ventricle will not be able to really deliver the blood from the right ventricle to the left atrium unless they passively increase the pressure in the pulmonary, basically arterial circulation above the left heart pressure to maintain the flow. So that's kind of what we call the passive, or that used to call really the passive pulmonary hypertension, or really the pulmonary venous hypertension. Now we call it a group 2 disease. Now really sometimes that process is really exaggerated, that really cause pre and post capillary pulmonary hypertension. Now group 3 again is very different and related to the hypoxia and the lung damage from different diseases, leading to destruction of the pulmonary capillary, hypoxic vasoconstriction, again leading to pre-capillary pulmonary hypertension. And in group 4, when you have chronic really fibrothrombotic really mechanism or really event that continue to really grow and occlude the vessel, leading to obstructive really pulmonary hypertension. As you can see, group 1, 3, and 4 are mostly in the pre-capillary component. Group 2, the problem in the post-capillary component. So what should we do when we start looking at those patients who are treatment naive? And the first things to do is to have very meticulous diagnostic algorithm, trying not only to diagnose that there is high pressure in the lung, but also to properly classify the disease. And there is a few things that we need to do based on the echo, the initial screening test, plus the lung imaging, VQ scan to look to really rule out group 3, group 4, and then right heart cath eventually to confirm the diagnosis. So this is a very, very meticulous diagnostic algorithm. And this is why there was strong recommendation in all guidelines that diagnosing patients, especially patients naive, to be diagnosed initially in expert center. A few words about the echo. We're not going to go into details, but the echo is quite important in the initial screening to really tell us what's the likelihood that this patient might or might not have pulmonary hypertension. So that depends on actually basically many factors, including what we call the TR jet velocity, and we look for other echo sign for pulmonary hypertension. So whenever you have basically slow TR jet velocity less than 2.8 with no other echo feature, we say that pulmonary hypertension is unlikely, or there is low likelihood for the pulmonary hypertension. Those who have basic TR jet velocity more than 3.4, that's very highly likely to suggest pulmonary hypertension. Anyway, in between, you need to have a combination between the TR jet velocity and the other echo pH signs. Now, echo is also, of course, important to rule out any structural disease. Look at the left heart, ejection fraction, look at basically valves, look at basically shunting. So echo is extremely important, not only as early diagnostic test or really screening test, but it helps also to really allocate the problem itself that might cause the pulmonary hypertension. But very important to really say that echo is only giving you likelihood threshold. We should never diagnose pulmonary hypertension, specifically when it comes to the treating pulmonary hypertension based on echo. And as we said, we look at specific pH actually sign at the level of the ventricle, looking for the size of the RV and the and the right atrium, the movement of the septum. We look at the level of the pulmonary artery, looking at the acceleration time. Of course, the slower that is, more likely to have really high afterload. We look at the pulmonary valve velocity and the diameter for the pulmonary artery, but also we look at the inferior vena cava, looking for the size and really collapsibility. So all of these pH sign by echo should be incorporated with the TR velocity to give you a likelihood for the presence of the pulmonary hypertension. Again, after you really screen in to say that there is likely to be pulmonary hypertension and echo showed no other cardiac causes for the pulmonary hypertension, we have to do very meticulous, really pulmonary diagnostic workup, including really lung function with the DLCO, really CT images, and sometimes we do cardiopulmonary exercise tests to evaluate for the group 3 disease. And VQ scan is extremely important because it has very high sensitivity for the group 4. So that's extremely important. And at least in non-PH center, when PH radiologist is not available in that center, CTPAs, basically spiral CT scan for the pulmonary embolism, is not good enough to rule out a really CTEPH. And as you can see here, the sensitivity is as low as 50%. This means that by doing CTPA, you might miss up to 50% of cases of chronic thromboembolic pulmonary hypertension. So the classical teaching is that CTPA is extremely helpful in acute pulmonary embolism. It's quite lousy in chronic thromboembolic disease whenever the really disease is very distal, and you can miss up to 50% of the cases. However, as I said, if you do have a PH radiologist that can look for other basically feature, not only the filling defect, but look for the really vascular, wall thickness and tortuosity, looking for mosaic attenuation, looking for collaterals, and looking for whips and bands, then that kind of radiologist, if you have it in your hospital, will increase the sensitivity of CTPA to close to the VQ scan. Then finally, as we said, right heart cath should always be done to confirm the diagnosis. So I think if you will take one message from me here tonight, we would say that without right heart cath, there is no pulmonary hypertension service. And the right heart cath is extremely important for many, many reasons. And this is why we'll look at the guidelines or guideline giving you the strongest recommendation to do right heart cath to confirm the diagnosis. And as we said, right heart cath, yes, number one, will confirm the diagnosis because as a matter of fact, the diagnostic basically really threshold of the mean pressure of 20 or really above can only be reliably measured by right heart cath. Echo will give you the systolic pressure usually. Really calculating the mean pressure by echo has a lot of really pitfalls. But beyond that, right heart cath is important to do reversibility to assess whether this patient is really vasoreactive or not. It will assess very important hemodynamics that we use a lot in the clinical practice to evaluate the severity and to really follow the patient. And it will be very helpful in evaluating the prognosis and risk assessment based on looking at not only the pressure, but looking at the right atrial pressure, the cardiac output, the PVR, the mixed venous saturation, and then as well check for the shunting. It is also important to look for the pre and post capillary really by looking at the PVR. And before that, in the past, we used to look for really other parameters such as the diastolic gradient or the transpulmonary gradient. So all of these information are extremely important during the right heart cath in order to basically evaluate the patient before starting any medical treatment. Now, after we confirm the diagnosis that this patient belonged to group 1, that is really what we talk about here tonight, how to do that. And the really important point, when it comes to those patients is initially, yes, establish the diagnosis, determine the group or the class where the patient will be. Is he going to be group 1, 2, 3, 4, 5? But then you need to determine what is your goal, or what are your goals of the treatment. And for example, we know that when we treat hypertension, for example, then it's very easy to say that the goal of therapy is to drop the systolic pressure towards less than 140, for example, and the diastolic below 90 or something like this. When it comes to the hyperlipidemia, we have specific numbers that we need to reach before we say that we are correcting the lipid profile. Very similar in diabetes, you need hemoglobin A1C less than 7, etc. But what is the goal of therapy in pulmonary arterial hypertension? Is it really to drop the pressure, to normalize the pressure? And the answer is certainly no. We do not want to drop the pressure. That's not the goal of our therapy. The pressure is important to make the diagnosis initially, and then that's it. So what do we really want to do is actually to keep the patient in the green zone based on certain parameters that belong to the clinical evaluation, exercise capacity, and right ventricular function. So we look, for example, for the sign of heart failure, degree of dyspnea, a WHO function class, and syncope. We need also to be sure that the patient had good exercise capacity. We want them to walk more than 440 meters. And we need to have very good RV function by looking at the pro-BNP level, really below 300. If you do echo, we need to have a TAPSE scoring more than 2, right atrial area less than 18, no pericardial effusion. And if you do hemodynamics, would like to have quite good cardiac output and low right atrial pressure. So as you can see, it is a composite endpoint that we really put together, and we call that low risk group, or the green group, as it's known really among the pulmonary hypertension doctor. So, and again, remember that this green group is a mixture of clinical symptoms, exercise capacity, and right ventricular function. Anytime the patient is really drifted outside the green zone, we have to adjust the treatment, as Dr. Hani will really tell us in a second about how to bring the patients back into the green zone. And to really summarize this, just to prepare the stage for Dr. Hani, I want to start treatment based on this the green, yellow, and high risk categories. Then we need to adjust treatment. But before that, we need to be sure that this patient who belongs to group 1 does not have very, very specific situation called vasoreactive cases. And the vasoreactive cases are the minority of group 1. And those patients during the right heart cath, when we give them a fast onset, short acting vasodilator, to great extent nitric oxide, we notice significant drop in the mean pulmonary artery pressure, more than 10 millimeter of mercury, to reach the absolute number less than 40 without a change in the cardiac output. So as I said, those patients are a minority. They are less than 5% of the cases, but you don't want to miss them for 2 reasons. Number one, their outcome is marvelous. Those people, they have very, very good outcome, not the outcome that I showed you at the very beginning of this lecture of very increased mortality. For example, those patients who are vasoreactive compared to the non-vasoreactive, you can see that the mortality is very, very different. I'm sorry. But the second important thing is that those patients can be treated by simple calcium channel blocker, which is cheap, relatively safe medication, non-complicated, basically methodology, and they do very well if they continue to be vasoreactive over time, because about 50% of them might lose this vasoreactivity over time. But if they continue to be vasoreactive, the treatment is simply calcium channel blocker, and those people do very well. But those who are non-vasoreactive, we go to the green zone, yellow zone, and the red zone. And you can see clearly now the guidelines said, whether you are on really green or yellow zone, the treatment should be initial oral combination. Those who present to us at really red zone, they are high risk, they have a lot of symptoms, very poor exercise capacity, very poor RV function, then the treatment is as well combination therapy, but that should include really parenteral prostacyclin. So these are now basically the group of medication that we use. To have medication working on the prostacyclin pathway, to work on the cyclic AMP, which is a molecule that induces vasodilatation and inhibits cell proliferation. That's extremely important. We use another molecule that's working on the nitric oxide pathway to accumulate cyclic GMP, which is again leading to basically relaxation and basically inhibit cell proliferation. Or we inhibit the endothelin pathway by very good molecules that inhibit the endothelin receptor A or A and B on the smooth muscle that lead to basically vasodilatation and inhibit cell proliferation. If you look at these medications, so these are the important studies that were done with really on the prostacyclin pathway using the IV epiprostenol in the basically mid-90s. That was breakthrough in the pulmonary hypertension because that drug made major changes in the outcome and almost doubled the survival for those patients. And actually, some of those patients who were on the transplant list, they were taken off the list because they did very well. But because there is a lot of really difficulties with the IV routing, there was the AIR study looking at the inhaled iloprost that again showed to be quite effective in patients with pulmonary hypertension to a great extent, group 1 and group 4, and showed that there was significant improvement in the 6-minute walk distance, which was the primary endpoint. In the Griffin study, which was one of the largest PH study using selexipag, which is a prostacyclin receptor agonist oral therapy, again showed that selexipag basically significantly reduced morbidity and mortality in those patients. Looking at the endothelin pathway, we have the BREATHE study looking at bosentan in patients with pulmonary arterial hypertension, and bosentan in the dose of 125 BID, that is now the approved dose, was quite effective in improving the 6-minute walk distance, which was the primary endpoint. The 250 was also more effective, but it was having more hepatotoxicity. Then the Seraphim study, again, which was one of the large really PH study, looking at morbidity and mortality, and macitentan in 10 milligram dosing orally once daily managed to decrease morbidity and mortality by 45% in those patients. And finally, the nitric oxide pathway, we have the SUPER study using sildenafil to basically inhibit the phosphodiesterase 5 really enzyme that usually degrade the cyclic GMP, was effective in improving the 6-minute walk distance. And more recently, riociguat, through stimulation of the soluble guanylate cyclase, has again shown very good efficacy in improving the primary endpoint and secondary endpoint in those patients. So finally, after the initial basically treatment choice based on, as we said, the green, red, and yellow, and then accordingly we choose really to start on initial oral combination or initial combination with the parenteral prostacyclin. This recommendation of the early really upfront combination came primarily from the AMBITION trials. Using 2 drugs was shown to be better than basically the mono component. So in this study, ambrisentan and tadalafil was tested against the really mono component, and find out that this combination therapy, upfront combination therapy, is very, very beneficial. And that led to more ambitious kind of really behavior to say that should we start by 3 drugs then instead of 2 drugs? So the Triton study was done to look for, should we start with 2 drugs versus starting with the 3 drugs from the beginning? The primary endpoint was looking at the pulmonary vascular resistance and 6-minute walk distance. And as you can see, there was no significant difference, at least at the beginning, from starting 2 drugs or starting 3 drugs from the beginning when it comes to the drop in the PVR or the improvement in the 6-minute walk distance between the initial triple therapy versus initial double therapy from the PVR or from the 6-minute walk distance. But when those patients were really followed later on, and I'm sure Dr. Hani is going to talk about this really in his talk, found out that those who were started on the triple therapy were less likely to have an event later on. Event means worsening in their disease, need to admission to the hospital, or mortality. So my take-home message to you, ladies and gentlemen, that we need to understand that pulmonary hypertension is a hemodynamic state. By itself is not a diagnosis. There is many diseases that can cause pulmonary hypertension, including lung diseases such as COPD, sarcoidosis, cardiac diseases, heart failure, and valvular heart diseases, many connective tissue diseases, infections such as schistosomiasis and HIV, liver diseases, blood diseases, etc. And sometimes it could be idiopathic. But in any disease, when there is pulmonary hypertension, then the outcome is extremely worse. Appropriate classification and grouping those patients into the 5 groups is really vital, because if you treat group 2 patient with group 1 medication, that might lead to actually catastrophe and increase mortality in those patients. As we said, PAH is rare, but PH is very common. And always remember that group 2 and 3 pulmonary hypertension are the most common. Finally, the role of echo as a screening test has been reinforced. Echo is extremely valuable as a screening test, but please do not diagnose patient as pulmonary hypertension. And more importantly, don't start patients on treatment before doing right heart cath. The really golden slogan, right heart cath, is a must. It's not optional in those patients. Finally, risk stratification, the goal of therapy should be identified very early, and we need to be very aggressive in treating those patients by starting the early combination therapy from the beginning. At the moment, we have 3 active pathways: prostacyclin, really endothelin receptor antagonist, and nitric oxide pathway that we are now utilizing extensively. And in the near future, we're going to have more active single-link pathway that we're going to target in our treatment. And with that, I would like to thank you very much for your attention.
Thank you very much, Professor Majdy. As usual, a brilliant, concise, and very effective presentation. There are 2 quick questions, and then maybe we can go to the second talk. So from Dr. There's actually questions in the Q&A chat. What are the risk factors for PAH, and do we have a prevalence within the GCC or Arab countries?
Sure. Basically, the risk factor for PAH group depends on the cause for it. For example, sometimes you have really familial, or what you call the heritable. It can run in the family, and we have a few patients that we have pulmonary arterial hypertension in 2 or 3 sisters, for example, or the mother and the daughter. So that's known with risk factor. We know that some drugs really can cause pulmonary arterial hypertension, including some of the tyrosine kinase basically inhibitors used in the really malignancy treatment. And in the past, it was those really appetite suppressant. Other risk factor, including diseases such as connective tissue diseases, to great extent, scleroderma is one of the most really important that we should not miss, because scleroderma and pulmonary hypertension means high mortality. So CTDs in general, basically some infections such as schistosomiasis, chronic liver disease that can cause portal pulmonary hypertension. So those are usually the condition that made us think about pulmonary arterial hypertension. If we have patients, for example, with scleroderma or the liver cirrhosis present with really dyspnea, one of the diagnostic workup should be to rule out pulmonary arterial hypertension. The prevalence really In the Gulf country, we don't have data yet available looking for their prevalence, but at least in two centers, really our center and King Faisal, we noticed that really the mean age for pulmonary arterial hypertension in these countries, basically in Saudi Arabia, was about 36 years of age. And that's very similar to the Chinese data. Chinese has reported that that's the usual age when people get the disease. In the West now, the mean age is in the late 50s. So it seems that we have some differences when it comes to that, but we don't have really clear prevalence data when it comes to the pulmonary arterial hypertension in the region here.
There's another two quick questions, and there's a comment from Dr. Faiz Al-Muteri about group 2 heart failure, out of proportion with very high RVSP. If you want to just maybe clarify, this is a very common phenotype and it's often misunderstood.
Right. So those people, they have, as we said, that in group 2 disease, because you have very high left ventricular basically filling pressure, the only way the RV can maintain the cardiac output by really vasoconstriction in the precapillary component to increase the pressure above the left ventricular pressure. And that's caused basically purely really post-capillary component. But sometimes this process is actually exaggerated and there will be some excessive basically proliferation. So the precapillary pressure goes way above what you expect. In the past, we used to call that out of proportion, and now we call that combined pre and post capillary. And we can identify that during right heart cath by looking at the mean, basically mean pressure, wedge pressure, and the PVR. So basically, whenever you have basically high wedge pressure, that will give you that will tell us that really there is post capillary component, and whenever you have the PVR more than 3, that will really indicate exaggerated precapillary response, and we call that pre and post capillary. I agree with you, that used to be called out of proportion. I personally like that name, but now the right name is pre and post capillary. That can be addressed sometimes in a specific treatment protocol in expert center. But if you have only post capillary, the treatment is not to treat the basically the pulmonary hypertension, but to treat the left heart.
So there's the question about, do we have from Dr. Kidan, do we have a PH center in UAE? I think we do. We've had the pleasure of starting the PH center almost 5 years now, and we've published our 2-year survival data. I think we have about 300 patients. Of course, we are, our experience allows a lot of the expertise from Dr. Majdy and his group that have shown us, the starting points is how to start programs.
Well, I can answer that you have an excellent PH center in Abu Dhabi. So yes, you do.